Good evening, everyone, and welcome to Plan Your Baby webinar. And tonight we are going to talk about a huge topic, and IVF became a treatment to achieve pregnancy, especially when it comes to very complex cases. And tonight we are going to talk about why IVF might not work. And I'm sure you are very familiar with the processes and the treatment itself. And statistically, still per patient on average, patient might require about 2.3, 2.4 IVF cycles. So that means that not always is going to work from the first attempt. And this is what we are going to discuss, why it may not work and what Plan Your Baby actually is doing differently and how we can maximize the chances of success. And we will use the chat in our webinar. Please feel free to introduce yourself, let us know where are you dialing from, and you can start to type the questions as well. I think the most exciting part is coming after, when we will have a Q&A session. Our doctors, Dr. Sami and Dr. Nora, will address all of the questions at the Q&A session. And please don't be shy. This is the amazing opportunity to get all of the answers. And if you've had a special treatment in the past, we can discuss this at the Q&A session. So for those who just connected and joined, again, good evening. And we are going to talk about the IVF and why treatment might not work from the first round. And we will pick up the most controversial topics during the webinar, and we'll discuss about the add-on, the close monitoring, and what exactly makes the difference to make treatment be successful. So yes, so Dr. Sami, would you like to go to the next slide? Thank you. So I have a fantastic team of Plan Your Baby joining us tonight, discussing the topic. With me tonight is Dr. Sami, the medical director of Plan Your Baby, and Dr. Sami has more than 20 years of experience, as well as our senior nurse, Anna. She's joining us and she will help us during the questions and answers. And our fantastic doctor, Dr. Nora. She has extensive experience in providing IVF treatment, and she will join Dr. Sami in presenting the topic and also answering your questions. Okay, so just to give you a bit of an overview who you are going to talk with tonight. So Dr. Sami has spent more than 20 years in fertility sector. He worked for private and NHS hospitals, and also lately he has been working for clinic ARGC and Plan Your Baby as a medical director. And we have Dr. Nora with us as well tonight. Dr. Nora has extensive experience in the most complex cases, more than 20 years in the field. And yes, so tonight Dr. Nora will discuss with Dr. Sami what exactly needs to happen to maximize your chances for IVF to work. Dr. Nora, the floor is yours. You're on mute, Dr. Nora.
Thank you very much. Can we have the next slide, please? So we're just going to start with a quick introduction to see, well, who may need IVF? You know, we hear lots of fertility treatments out there, but when it comes to IVF, we divided them into different factors. So there are female factors, male factors, or diverse family building. So for female factors, it could be age-related, that maybe there is an increased age with diminishing egg reserve. We can have tubal blockage, endometriosis, PMOS, which is PCOS. This is its older name, and exciting stuff to discuss hopefully in the future with us. Okay, recurrent miscarriages, and sometimes we do IVF just for the purpose of freezing eggs, whether it's you want to freeze your eggs to make sure you have options in the future, just like having money in the bank, or if there's going to be cancer treatments. So there are different options there, and we sometimes have to start with IVF. Other things are male factors. If there's any issues with the sperm, blockages, for example, that the sperm can't be released, and failed fertilizations in a certain way, testicle is not working properly, and so that's why, we need to bypass these using the technologies we have. And one last category is diverse family building. And so same-sex couples, they can have IVF if, for example, seeking reciprocal motherhood, having surrogacy, and also we have trans individuals if they would like to have gamete freezing, and as well as non-binary and intertrans family building. So it's really, not one size fits all. Everyone has a place and has a different technique. So when we go back, we always check cycles and see, why is IVF not working? And, sometimes we could say, hey, it may be just bad luck. But we have to go back and evaluate your cycle really, really precisely. It's really important to see how the stimulation was. So we don't have a one-size stimulation. It's tailored to you, depending on parameters. We double check if male factor was looked at properly. So a Plan Your Baby, the protocol is personalized for you after taking lots of things in aspect. You have a fixed team that's taking care of you. So there's continuity of care available 24/7 on WhatsApp or email. Is it the transfer timing of the embryo? So again, we need to assess lining, assess if you're ready for that embryo transfer. And, other factors could be unexplained. We can look into it and see if there's any clotting factors that may be causing this, or immune ones. Is there something that wasn't investigated before? And of course, we discuss egg quality and quantity, but that comes as a personalized thing. Next slide, please. So when we talk about advanced IVF options, well, how can we use it? So the way we do is we collect eggs. So one option is to go for something called IVF fresh. And IVF meaning we're collecting your eggs, we put the sperm with the eggs in the lab, we let them marry, and we transfer resulting embryo during the same cycle. The other option is maybe a bit more, to assist the sperm, for example, or for other reasons, and we'll show you in a bit. IVF with ICSI, it means we inject the sperm into the egg and we observe how the embryos develop after that. And that's to overcome failed fertilization that can occur in some couples. So that's a technique that we have handy. Other things is IVF or ICSI using egg or sperm donor. We usually use IVF. We have good quality sperm. And this is depending. We help in selecting a UK compliant donors and, make sure that everything is in check, good quality. Infection screening and genetic screening is great. Okay. And the last thing is to do genetic testing with IVF. So it can be done for health condition or checking or screening embryos. All right. So you can see the diverse options. Next slide, please. So just to take you along with what IVF treatment means at Plan Your Baby. So stimulation starts. So you let us know when the period starts, and then there are scans and blood done every other day. The whole purpose is to try and modify the dose, and we want to have synchronized follicle growth, and at the same time we don't want to overstimulate or understimulate. We want to be at the sweet spot where we get good eggs and not cause hyperstimulation or complications. All right. So all this is done locally where you are with the regular blood tests and scans that can be arranged, and even bloods can be done at the comfort of your own home. Once we're happy with everything that's going along and it's time to trigger, then you will take a trigger shot and come to the partner clinic to have the collection, and after that the transfer. So everything is available nationwide and at your comfort. It's just that part that we need to go with one of the IVF partner clinics. Next slide, please. So after that, once the embryo transfer is done, we want to do a blood test. We can do urine test as well. So the blood test is to monitor hormones to make sure you're getting the appropriate support for this period until we reach the pregnancy test time. And then we also offer pregnancy monitoring and scans to check viability. So it's hormone blood test to make sure all is in check. Next slide. So one last word about IVF with donor eggs or sperm. So, donor eggs are sometimes recommended with, for example, individuals who don't have eggs or have very low number of eggs and have been trying for some time, multiple IVF failures or miscarriages. So it is considered. If there's a genetic condition where, for example, we don't have ovaries, okay, then donor eggs can be considered. But one of the most things is age-related fertility decline. In addition, with family building, we have, male same-sex couples or trans non-binary couples that may require an egg donor. Okay. For sperm donors, it's different. It's to bypass male factors. So if we have a severe male factor, meaning no sperm, even they can try surgical sperm retrieval and didn't get sperm, then they can use donor sperm. If there are genetic conditions in the male partner that they want to bypass, single women, female same-sex couples, and also trans non-binary individuals trying to build a family. Next slide, please. So just to show you pictorially what IVF and ICSI means, I mean, we hear a lot of things. IVF, like I told you, we put the sperm and eggs together in the lab, and it's really important to have good quality sperm and that they hit targets of parameters to be suitable for IVF. So the sperm is basically on the day of the egg collection is what decides. And especially if they have good previous fertilization and a good number of eggs. Sometimes if the eggs are really low and we don't want to take a chance, we go ahead and do ICSI. Again, IVF is still can be still used. If ICSI, it's spelled ICSI, but it's pronounced as ICSI. So it's just one sperm selected, the best looking, best swimming sperm is selected under the microscope and injected in the egg. And we use that when there's previous failed fertilization with IVF. So maybe there's an egg factor or barrier that we can cross and hopefully get them closer together to fertilize. So if there's any male factor as well, like testicular sperm, or if we're using frozen eggs, then we always go for ICSI.
Thank you, Dr. Nora, for that information. It's very useful. So there's a lot of interest nowadays. It's becoming more common, actually, and even in the UK, to do something called PGTA, pre-implantation genetic testing for aneuploidy. So what is this exactly? Well, in some cases, we recommend that the embryos are genetically identified before we transfer them in terms of the number of chromosomes. So what we want is we want to have the embryo with the normal chromosomal makeup, the normal number of chromosomes. We call it euploid. And this embryo will have the highest chance of resulting in a successful live birth, lower risk of things like Down syndrome, Edwards, all of these which are linked to the number of chromosomes, we can pick up with pretty good accuracy, about 98% nowadays. It can also lead to lower miscarriage rate as well, because the commonest cause of miscarriage by far is a chromosome abnormality. And it's really horrible, especially for someone who's gone through IVF treatment, fertility treatment, maybe been waiting for a long time to get pregnant, and then they achieve that pregnancy, but sadly it ends after a month or two and in a miscarriage. It's really, really a difficult thing to go through, and it takes up time and is associated with a lot of heartache. So this PGTA may help reduce that when it's miscarriage related to chromosome issues. Of course, it doesn't remove all causes of miscarriage, but the chromosome is the commonest. And especially for older women, this is quite a big thing. Now, also at Plan Your Baby, we are interested in following all of our patients who do IVF or get pregnant through fertility treatment, or sometimes we get people who have recurrent miscarriage who got pregnant naturally. And we are very interested in the first trimester because this is the most critical time. So we will monitor very closely the first trimester in the initial phase, the first as soon as you get the first test. We do blood tests every 2 days, every other day, 2 or 3 days, for HCG, the pregnancy hormone, and progesterone. And we can adjust the supportive progesterone dose and supportive medication that are given based on these results, because sometimes it can dip. And if there's too much drop in progesterone, that can then lead to bleeding, or even the pregnancy can be lost. So we want to make sure that we keep on top of that until we get to around 6 weeks. And then once we get to 6 weeks, we can do the first ultrasound scan. Hopefully, we see a heartbeat and the pregnancy is in the right place, at which point we can reduce the intensity of monitoring to every 7 to 10 days. Usually we'll do a blood test for progesterone and an ultrasound scan until we get to 12 weeks. And then if we get to 12 weeks and everything is looking good, the risk of miscarriage is very small after that. So we can release the patient back to routine NHS care and it should be fine. And this monitoring is done locally. So you'll find somewhere fairly close to you where you can go and get your blood test and ultrasound scan done. And usually we don't follow into the second or third trimester, although if you are interested, there is an obstetrician that we can recommend. So today's talk is about people who have failed IVF, and unfortunately, this is something that we see a lot of. Unfortunately, IVF is not a treatment which works every time. I wish it did. And sometimes it can just be bad luck, yes, but sometimes there could be a reason for why someone's failed their IVF, and that could be a recurrent reason. And therefore, it's very important not just to keep doing the same again and rushing straight into doing treatment again and again when things aren't working well. So we've got tonight for you 2 cases to present, patients who came through Plan Your Baby after having treatment which had failed in other clinics, and they thankfully were successful with us with the first attempt. So this first lady, she was 42 years old. She'd had 3 miscarriages, recurrent miscarriage, and she'd been trying for quite a long time. 5 years she'd been trying for a baby. She did treatment in 2 clinics before coming to us. First clinic, she did really well. She got 23 eggs, 19 blasts, which is an amazing number. And she decided to go for the genetic test, the PGTA. 6 embryos were checked out of the 19, 4 healthy, which is a good proportion actually. But she then went on to fail her transfers with 4. She transferred 2 untested. She had biochemical miscarriages. She then tested another 10. She got 6 healthy, transferred another healthy one, euploid, got a negative result, and then decided to move to another clinic. She then moved the remaining 5 embryos, which were tested and healthy, to this second clinic. She did immune testing with them, did find some high natural killer cells, some immune activity, which wasn't good. And then did another frozen transfer. She had extra treatments this time. She had IVIG, which is an IV drip, to calm the immune system, to calm the natural killer cells. She had steroids. She had blood thinners, Clexane, which is a heparin. She unfortunately still got a negative result. So she then came to Plan Your Baby. She'd had 7 failed transfers, not had any baby, unfortunately. There was a hysteroscopy that we asked her to do because of the suspicion on ultrasound that there could be a polyp, and that polyp was removed. We also checked with her immunes something called cytokines. So these are protein activators for the immune system. She had high cytokine levels, so we gave her Humira, which is a TNF blocker, to deal with that prior to the frozen cycle. She then started the medicated frozen cycle, and she was also given some Viagra, which is something that can help improve the blood flow to the uterus to improve the lining development during that initial phase when we're building the lining. And I also gave her some low-dose steroids, intralipids, which is another type of IV drip to calm the immune system. Again, blood thinners, and progesterone was in the form of injections. So she had 1 embryo transferred. She had a positive pregnancy test. We followed her pregnancy until 12 weeks, and thankfully she was successful and had her baby. The second lady, she was a younger lady, but she had very low egg reserve. Her AMH was around 2. So it was a challenge really to get eggs from her. There was also a male factor, and she went to her first clinic in 2021. That was a long time ago. She had a full stimulation, 4 eggs, 3 fertilized, 2 embryos put back, and she had a baby straight away. But she did have immune treatment with that with that transfer and in the pregnancy. So she had IVIG, which is an immune drip, dexamethasone, which is a steroid, and Clexane. So she was lucky. She got successful with the first attempt, but then she went back. She did a frozen transfer. She took these same drugs, but that embryo didn't survive, so she didn't have a transfer then with that attempt. She then went with that same clinic and did another full stimulation. Only got 2 eggs this time after a couple of years. Her egg reserve had become lower, so she only got 1 embryo, was transferred. She again had the same treatments, but didn't succeed with that one. So then she moved to a second clinic, and this clinic, they encouraged her to do genetic testing. So she did a few cycles. She had 3 cycles to get the genetic testing done. She had healthy embryos from both of the cycles where she did actually get an embryo. But yeah, she did transfer 1 embryo and it didn't work. So then she ended up with a miscarriage in that cycle. But that cycle, she didn't have any immune treatment done. So when she came to Plan Your Baby, I asked her to check her microbiome, and we did find that her lactobacilli, which is the healthy bacteria, was very low. So we started on probiotics, and then we repeated some immune tests. She still had high immune activity, so I recommended that she went back on some immune treatment. So she had a medicated cycle, steroids, IVIG, the immune drip, steroid, progesterone injections, blood thinning injections, aspirin. But thankfully, she had one embryo. It was her last embryo. She told me that if it didn't work, she wasn't doing any more fertility treatment. But thankfully, it worked out nicely. She got a positive pregnancy test. We followed her until 12 weeks. We made sure she had enough progesterone, immune treatments to cover her for that critical time. And this time she did have a live birth and had her second baby that she was hoping to have.
Dr. Sami, thank you so much. And I think, every time when you present case studies, I mean, it's encouraging me a lot, talking about why exactly it matters so much, not only just the precision, but understanding each individual case and paying attention to detail and finding out exactly, the cause, what can make treatment be successful. And just before we'll go into the Q&A session, I just would like to explain, so how exactly the IVF cycle can be provided at Plan Your Baby and why patients come to us. So number one is that your precision, the IVF cycle with every day or every other day blood tests and ultrasound scans will be done from the comfort of where you live. So that means it will remove the constraint on time and also the financial constraint to travel to the clinic. And also, Plan Your Baby, to support this treatment, implemented a mobile phlebotomy, which is one of the most popular services we offer. Actually, the blood test can be taken from the comfort of your home while you're having a breakfast, and then our courier will come and collect the sample from your home. And we do have this support service across the whole country with no limitations. We, of course, do receive the results on the same day, and the allocated nurses will then follow up with you with all of the instructions. We'll have a call. You will receive detailed email with all of the instructions, and you will have ability to communicate with staff over the WhatsApp as well, which simplifies a lot, especially sometimes when you try to speak to reception, lines are busy, you can't get hold of the clinic. And I think one of the most important parts here that Plan Your Baby works 7 days a week with no exclusions. So either it's Saturday or Sunday, you will be able to speak to a nurse at 7 p.m. in the evening. And to support your treatment, we do send medications with a courier to your doorstep. So you don't need to worry that you need to go to any local pharmacy or travel to London to collect your medications. Everything what's related to your protocol will be delivered to your doorstep. And then Plan Your Baby, of course, provides you before you start the treatment with a very detailed plan around your protocol, what kind of treatment exactly you will have with end-to-end costs and no surprises. Dr. Sami, would you like to go to the next slide? Okay, so I think when it comes to choosing the clinic and the differentiators about Plan Your Baby and maybe a very traditional conservative model of IVF clinic. So Plan Your Baby offers you an extreme flexibility and adjusts everything around your scheduler rather than asking you to commute to a certain location and have this huge inconvenience around the appointments, especially because we are offering very, very close monitoring. So when you think of your blood test will be performed during the IVF cycle pretty much on every other day basis and closer to trigger even every day, and we will make all of the decisions based on your hormones, it is important to have this level of flexibility. You only then would need to travel to London for your perhaps maybe last appointment, so we can get the results very, very early in the morning, and for egg collection and embryo transfer. And then when we go to post-embryo transfer monitoring, which I would really want to touch slightly closer when we get to the Q&A session. So this is the monitoring that involves the blood test, and very often every other day before the pregnancy test also can be done remotely rather than worrying and traveling after the embryo transfer to a certain location. Okay, next slide, Dr. Sami. Okay, so the process itself is very similar. You have usually a consultation with Dr. Sami or Dr. Nora, and the initial consultation would involve a very detailed plan, a medical history assessment, to understand what treatment is best for you. Now, very often, based on the initial consultation, there might be some investigations that doctors may ask you to complete. Of course, we will not ask you unnecessarily to repeat the tests that you have done either with your previous clinic or NHS or your GP. So all of the tests that you've done in the past, we will accept and will be reviewed, and only necessarily tests to understand the actual reason why you have not been successful yet will be advised to do. And then the next day you receive a detailed plan about the protocol, about your treatment, and of course detailed costs about the protocol, what exactly the treatment will involve. And then you will have a call with a nurse to discuss every single step, the process, that you will be sent consent forms, and then the treatment can be commenced. So usually this takes a very short period of time before you can start treatment without any unnecessarily delays. Now the investigations and the preparation for the treatment will involve yourself and the partner, either it's a female or male, and both will need to complete the consent forms as well. Dr. Sami, would you like to go to the next slide? Okay, one of the most important parts, what exactly we do for the patients at our clinic, is we understand that sometimes a holistic approach can make a difference. And what we have done for this to address and to make sure that we will cover a complete view on your treatment, we have included to every IVF cycle with no additional cost a nutrition consultation and the review of your lifestyle, of the supplements you take. And then the nutrition will provide you a detailed plan on what changes needs to be made to maximize your chances. And then we have also included a consultation with psychologists, because we understand that IVF is for sure is not the easiest treatment to have. It does carry a lot of constraints about the finances. It's also very stressful, and very sadly we see that sometimes it can separate partners, and it can create a lot of tension within your relationships. So we really do we do see that, and we don't want to leave it as if it's not part of your journey. So you will have a dedicated psychologist to have a consultation either at the beginning of the treatment or at the later stage, which then you decide how you would like to have it, and at what stage you feel it's this is the time that you need this support. And then there will be a doctor and nurses allocated to your treatment. So there won't be a situation where you call the clinic and the staff will not know about your case. There will be dedicated nurses, a doctor who will review your results, and always will be there for you if you need to have a private chat or discuss something. And again, as I said, to help this process, when you feel like the work is not supportive and you need a bit of more flexibility, you can always send a nurse to your home or to your work to do the blood test for you. Our couriers will take care of everything. We'll collect the sample, and then we will follow up with all of the instructions. And then the most important, that we don't discharge you after we receive a positive outcome. We believe that there's so much more that has to do with the fetus development and things that really can go wrong after the implantation, because your hormones changing, you need different dose of medications, and we will be there to support your pregnancy at least until 12 weeks. And then when we know it's safe to be discharged to NHS, then we can have this smooth transition to NHS. We provide the letter, a full explanation about your treatment, and then you can have a consultation with the hospital, who will then look after you and deliver the baby. And as I said, the process communicating with us is very, very similar, so you can just WhatsApp. Now, another very important part is the costs. Plan Your Baby is a private clinic, but we are very flexible in terms of how we try to support patients when it comes to finances. We're very transparent about how much your treatment will cost. You will be provided with a detailed end-to-end plan based exactly on your protocol, exactly on the medication plan. and what treatment you need. Now, one IVF cycle is approximately between 8,500 to 10,000 pounds. And if we need to use any donor gametes like egg donation or sperm donation, the treatment is slightly more expensive because it involves the potentially a frozen gamete importation, choosing the donor, and etc. And pregnancy monitoring, there is no any management fee once you achieve the pregnancy, so you don't need to pay that. It's included in your IVF cycle. And also for IVF treatment, there are options to have a financial plan. So actually you can break the payments into the 12 months with no any interest. So sometimes this option can be quite helpful. And we work as well with a lot of employee benefit companies and insurance companies as well. So if you do have any fertility perks with your employer, perhaps we work with them, so you can just let us know. Dr. Sami, the next slide, please. Okay, and now the most exciting part as well. We do have a lot of you joining to our webinar tonight, and we have unlocked more slots for the initial consultation. And Dr. Sami and Dr. Nora kindly provided you a discount just for the next 2 days to book a consultation for £99. And also, if you do feel that IVF is the treatment for you to have, and unfortunately, the other options are not there to support the achievement of the pregnancy, we do offer a £500 discount on IVF treatment if the treatment starts within the next 3 months. So if you would like maybe just to grab the QR code, but otherwise my colleagues as well to help, we'll just put it in the chat group so you can access the link into the chat group as well. So just not to lose this opportunity. Next slide, Dr. Sain. Okay, so another slide. So just if you would like to chat with us or you would like to leave the feedback, please just proceed with the QR code, and you can leave the feedback and let us know what are your thoughts. Was this webinar useful, and how did you feel about this? And it's always nice to hear the feedback or any questions or anything you would like to discuss in the future. We are open to suggestions. There's so much more that we can pick up as a topic. So now we will go through the questions. And Dr. Sami, so tonight the topic is, so what exactly can make IVF treatment work? Unfortunately, as you said, I wish we would be in a situation to make it work from the first round as a guarantee for absolutely everyone, but sometimes we can't go against the nature, and sometimes not always we know from the first round of IVF. So as well, we'll learn a lot during the IVF cycle. So can I ask you, what is the most unusual that you witnessed in the last 20 years? What Plan Your Baby is doing right now and other clinics are still not, in terms of the monitoring, and why it's not done by every clinic?
Well, I mean, you're right, Maria. Unfortunately, IVF doesn't always work, and there are things which are beyond our control. So as much as we try and control things and understand and get on top of things, unfortunately, the things that we just can't know or control yet. I mean, this is a very rapidly developing field in medicine, and every 10, 15 years, there are huge breakthroughs which improve treatments, improve success rates, new protocols, new drugs. But yeah, where we're at, we have to work with what we've got in terms of knowledge. We have to work with what we've got in terms of also physiology of the patient. So, some patients, they're very tricky to get multiple eggs, or with older women, it's not easy to get healthy eggs and embryos. But the most important thing, I believe, when you do treatment is that you do it in a way that you feel you've done everything possible. You've done the best that you can, not to feel like, oh, maybe if I'd done this or that, it might have been a better cycle, because that is the most important thing in my view. And certainly for someone who's failed IVF before, IVF is not just a treatment, it's a diagnostic tool. And if someone fails, then we should look very carefully at their notes. So if they're from a different clinic, they should request a copy of their file, the full file, and we can see everything from their investigations, their medication, their scans, their embryology sheets, everything will be there. And sometimes you can, if you look at that carefully, you can pick up things which may be obstacles or problems or things that could be done a different way, perhaps, and result in a different outcome, because it's definitely not one size fits all with IVF. There is some tailoring that can be done, which sometimes works better. Some drugs work better for some women, some protocols work better, some treatments work better in different scenarios. So there is, I'm afraid, sometimes also some trial and error, and sometimes just doing something different in itself can make the chances better. Of course, I can't say every time that's the case. Occasionally, you may see a situation where you just try the same thing again and it can work, because there is some luck involved as well in this. But certainly with Plan Your Baby, we like to monitor very closely follow the hormones, adjust the hormones to keep them in close range with the medication that we use, make careful decisions about when we trigger, what trigger medications we take, what progesterone support post-transfer. Pregnancy, once you're pregnant, that's not enough. We want to make sure that we've done everything we can during that critical first trimester, because you don't want to just get pregnant, you want to also have baby. So I think these are things that really kind of differentiate clinics as to how much care and attention they pay to these things.
Thank you so much, Dr. Sami. Dr. Nora, we have a lady who is asking quite sensitive questions. So from London, 40 years old, three ICSI rounds. So first round, no euploid embryos of 13 eggs collected. Second round transferred euploid PGTA tested embryo, but ended in miscarriage at 6 weeks, which is very, very sad, especially with euploid embryo. Now the third transfer, two blasts ready to transfer, but very low grading. And just to add to this question, the reason for IVF is the husband had a vasectomy with his ex-partner 13 years ago, had a reversal since they got married 4 years ago, but it failed. So we had a sperm retrieval operation, but the sperm wasn't the best grading either. And lady has endometriosis, adenomyosis. So, so these are all of the challenges that they are facing. It's a very, very complex medical history. I know there's a lot of aspects in this question, but if you could address it, that would be wonderful.
Yeah, thank you so much for sharing your story. I mean, I could see that you've been through quite a lot, and it's great that you didn't give up. Sometimes we feel down or deflated, but the good news is you have two blastocysts that are ready to transfer. And I just want to share something is genetic testing is something completely different from the grading they do under the microscope. So grading is subjective. I know it tells us what the embryo looks like, but low grading, high grading, it doesn't mean you will have an abnormal baby. It doesn't mean that this can cause a miscarriage. You'd be surprised that some couples transfer the last embryo they have, which was the lowest grade, after 5 transfers, and that's the one that got them the baby. So I know we do it for, it's subjective again, and we do it to try and grade embryos as a way to transfer, but it doesn't mean it won't result into a pregnancy. So, I mean, the good news is that you have, two blastocysts. So that sounds very positive. And, sometimes we offer also that you have a double transfer to up your chances again, because I realize you're 40, you have adenomyosis and endometriosis. So, I know it's difficult, but you can think about it and consider the advice we're sharing.
Thank you. And like Dr. Sami presented, we did see a patient, unfortunately, with a euploid embryos where the transfers just, wouldn't result into pregnancy. And I think it's so important to look into the monitoring itself, and maybe to support the environment, something needs to be done. It could be the immunes, it could be like, in that case, perhaps a hysteroscopy, but it needs to be really looked at the medical history so we can understand why did it happen, how can we potentially, prevent this, and especially with adenomyosis, like Dr. Nori said, and endometriosis. Sometimes there is, special protocols that needs to be applied to address this, especially if it's an inflammatory, conditions that can impact the other systems as well. Dr. Sami, another question. So any idea, so why NHS is not looking into the uterine receptivity or genetic testing of the embryos? And if we already have enough evidence that this can help, especially, with genetic tests for certain patients, certain age, and is it possible for Plan Your Baby to address this during or before the IVF treatment? And I don't know if patient meant during the NHS treatment. Can we step in? If you could maybe answer this question.
All right. So yes, I mean, she's asking quite a few things here, but first of all, the uterine receptivity, it's a big term, it covers lots of things. Basically, it means how easy it is for that embryo to implant and grow inside the uterus. And it covers things like, for example, the immune system, because if there is too much immune activity, then that is sometimes negative in its impact against the embryo, and the embryo can really struggle to implant, and it can prevent pregnancy. Or if it does manage to implant in those first few weeks when it's growing, and it's still very sensitive, very delicate, it can then be susceptible to, again, problems because of that immune attack. Too much is not a good thing, but also the implantation is an inflammatory process. So you don't want to oversuppress. The idea is to get it right, and the way to get it right is to do immune testing and find out, is there overactivity, where is the overactivity, which drugs are going to be the most suitable to treat, not just blindly giving things like steroids or IV drips when you don't actually know if this is helping, or maybe sometimes may make things worse than rather than helping. There is another aspect of uterine receptivity that maybe this woman might be asking, which is the endometrial receptivity assay ERA test, or there are similar ones from other companies as well, where a biopsy is taken from the uterus at the time after preparing the woman as if she's having an embryo transfer. And this biopsy is then sent to an overseas lab. They will look at the genes as a genetic test, and assess from these genes, is this lining in a state which is ready to receive an embryo or not. And this is not new. It came out probably 12 years ago, I think, 2014, if I remember correctly. And we did start doing this actually at that time, but it did quickly become apparent that it wasn't really up to scratch. And I was seeing patients where they had this test and they were told to to do the embryo transfer at a specific time, and it's given in a very narrow window within a few hours. And they did it, it didn't work. And then we did treatment. They came to a different clinic. They did treatment without following that guidance of the timing, and they got pregnant. So even back then I started to have my doubts, but the initial studies were all made by the company or sponsored by the company who made this test. Therefore, they were a bit questionable in how positive they were. But since then, since 2020, 2022, there have been two big studies, independent studies, which have shown that actually this is not helpful. So I think there's been a big move away from it now. Most clinicians don't do it. There are still, I know, some who do, but it's not something which is focused on nowadays. And the reason is it's just not really, I mean, the idea is great. You have this implantation window, and this test, if it helps to identify that, that's great. But actually, I think the implantation window is much wider than just a few hours. Even when you think about natural conception, I can't believe that it takes exactly the same amount of time for the egg and the sperm to meet, and tubes are at different lengths, and sperm is at different speed. And by the time it gets into the uterus to implant, there is a wide window. I don't believe it could be with 3 hours or 6 hours window, and that's it. And the studies are not really supporting this test. Now, of course, the NHS won't look at these things, any of these things, because they are expensive, and the NHS, they have to fit within a certain budget, that the IVF treatment, and it's a very limited budget, so they cannot add in these extra things, which cost a lot of money. PGTA, where testing of the embryos is done, it can be done in the NHS in certain circumstances, like recurrent miscarriage, but it depends a lot on where you are living, your postcode. And actually, most postcodes, I think, in the UK, it will be difficult to get genetic testing unless there's a strong medical reason for it. Dr. Nora, what's your experience with PGTA in the NHS?
So in the NHS, well, where I work, we don't offer PGTA. we only offer PGT, SR, or M. And SR, are patients that have also recurrent miscarriages or failed implantations or ectopics, but there's a missing gene or a shuffled gene. So something in the genetics is not straight in the parents. And so we test the embryos for those once detected. So it is, so those are the ones that are offered. They're free on the NHS, and they usually give them multiple up to 3 cycles, because we know that affected embryos are discarded. With regards to receptivity testing, we don't offer receptivity testing. There's no evidence for that it's helpful.
Thank you.
Thank you.
Thank you so much, Dr. Nora. We have very interesting question, and I think it's something that we really should cover as well. The question is it usual for PGTA tested embryo to end with unembryonic pregnancy and miscarriage? To be honest, I have not heard about this, but would be great to hear your opinion.
It's not usual, no. So with PGTA tested embryo, miscarriage rates should be lower. And for example, for Catherine, our first lady, was asking the question. She was 40 and she had a tested embryo, which very sadly ended in miscarriage. But at the age of 40, her background risk for miscarriage is approximately 30%. Most of that is chromosome related. And with PGTA, we'd expect it to drop a lot. So 8 to 10% it should be. Yes, there are other causes of miscarriage, of course, which PGTA won't cover, but it should significantly reduce the miscarriage rate, because 70% at least at that age of miscarriages are chromosome related. So yes, you can still, unfortunately, miscarry with PGTA tested embryo, but if someone does miscarry with a PGTA embryo, which is most likely healthy embryo, 98% likely to be genetically sound, then we really need to scratch our heads and think, why is this woman miscarrying with a healthy embryo? Or even if she doesn't implant, why is it not implanting? It must be the environment. It must be something which is not quite right. And we need to maybe dig a bit deeper and look into optimizing the environment, checking things that maybe need to be rechecked or checked again, things like thyroid function, vitamin D, blood sugar control, maybe ultrasound scans, or checking the cavity of the womb with a saline scan or hysteroscopy, looking at the immune system, thinking about giving blood thinners, which can cover for clotting problems. So yes, if someone is miscarrying with a healthy embryo or not getting pregnant with a healthy embryo which is tested, we really need to be scratching our heads a lot and thinking about this and planning what to do, and not just rushing to put the next embryo in, because there may be something there which could need some treatment. Yes, sometimes the embryo doesn't implant because of embryo. There's some issue with the embryo because PGTA doesn't test everything about the embryo. There are other things that we don't know, not just the genetics, but this is less likely. So, we have to really be careful here.
Thank you so much. I have another question, Dr. Nora. So AMH is 1.76. Now, doctor says 4 eggs and 2 embryos considered good, but no plan to change protocol. Is it realistic, or would you expect a better outcome? And I think we actually do have a few cases to bring up here to top up the answer here. Dr. Nora, what is your experience and view on this situation?
So if I'm assuming you're using the UK, 1.76 picomoles per liter is the one that we use. So 4 eggs and 2 embryos are pretty good, depending on the age of this person, which is not disclosed. So it's pretty good. Sometimes we get lucky. When the AMH is on the lower side, sometimes ovaries may misbehave. So I remember, at a low AMH, I got more eggs, and sometimes we get less eggs. So there is something called intercycle variability, that the person with the same dose can have different responses. But, it's very important to go back and see the protocol and see if something can be tweaked. Some women respond to some medications better than others. But if you say if this is a good result, to be honest, it is a good result, because with an AMH of less than 2, this is considered pretty reasonable.
Yes, and the lady just replied as well. She's 39 years old.
Yeah, so that's...
Thank you so much, Dr. Nora.
Thank you.
And now the question from my side, because I've seen so many cases where the outcome can be very different despite of AMH level. Anything that can be done to improve the number of eggs? I know that we are stick to the number. The number is so important.
Yeah.
Some know it's equality, but what can we do to improve the number?
So definitely, I agree. Equality is the most important thing, and we've seen so many women who just produced one egg, got a baby from it, and even the last case that I presented to the second lady, she had very low AMH and she had very few eggs each cycle, yet she still managed to have 2 babies. So definitely, quality is much more important than quantity, and sometimes it's a bit easy to get focused too much on the quantity. But sometimes you can try a few things to make a difference. Not all of it's going to work, unfortunately, but yes, I do feel that we can sometimes tweak the protocols, maybe changing the medication that's used, maybe adding in things that may sometimes work for some women, like adding in some steroids during the stimulation. Some women can respond a little bit better to growth hormone injections, sometimes even a bit more extreme, but to do PRP injections, platelet-rich plasma into the ovary. It works for some people, definitely not the majority, but these are things that can be considered. Fortunately, though, there's no guarantee that we are going to get more eggs, and at the end of the day, it's not the most important thing anyway. Even with 4 eggs, 2 embryos, you can still hopefully have a baby.
Thank you so much. I have one more question, but I think it's actually the question maybe to finalize the webinar with, and it's coming with very heavy heart to read it. Now, so what causes 4-time failures of IVF? And when patients go through so many failures, now we start to think of, can a surrogate be advised for this situation? And is it actually an option when we, witness so many multiple failures? And at what stage patients should start to reconsider options? It's the hardest decision, like by far, I think, to make. Anything to add here?
Oh, I mean, definitely repeat IVF failure is a really difficult scenario and extremely stressful for the couple. There's a lot of heartache financially. Sometimes relationships can take a toll as well. So it's a horrible position to be in. And the most important thing, like I mentioned earlier, is that we look very carefully at these cycles, what has been done, what hasn't been done, what maybe could be done different, what other tests may be needed. Has this patient had immune testing? Has she had any blood thinners with blood flow? Are there any other tests that should be done? Checking the uterine cavity more carefully, because there are times where we do these things and we find issues and we treat them, and people have been successful. And I've seen, I've been doing this for a while now. I've seen couples who've been trying 10 failed IVF cycles, 13 failed IVF cycles, and the most, probably nobody's going to believe me, but the most I've ever seen someone do and succeed is 23 failed IVF cycles, not a single pregnancy. And then 24th cycle, she actually had baby. This was over 14 years. And it can still be successful at the end, yes. Surrogacy might be an option, but it's definitely the last option. We'll always look to see what other things can be done. If there is, a healthy embryo being transferred and we've tried whatever we know and understand and it's not working, then we could look at surrogacy, but actually it's extremely rare that we need this option. Most of the time, we can optimize the body and try and fix things without needing to go for a surrogate, because surrogacy is not easy. It's a legal minefield. It's very complicated and definitely not something that you need to do unless you should do unless you need to.
Yeah, I wanted to echo that. Yeah, surrogacy is a really big decision and it has lots of legal implications. With multiple IVF cycles, you want to make sure that they actually have any transfers, because I also came across someone who had 4 IVF cycles but never had any embryo transfer. So, that's something to consider. Is there any egg factor? So, or sperm factor? Because sometimes we replace the sperm with donor sperm or with donor eggs before jumping into surrogacy, but I'm assuming they're making a good number of embryos, so sometimes just it's hard, but trying again.
Thank you so much. I didn't want to finish the webinar on this topic, but I think it's so important when we, discuss all of the options. I can see already we have some consultations booked with your doctors, so that's exciting. That means that, you know, we've been here for a very important topic, and many patients need support. So Dr. Sami, Dr. Nora kindly offered a nice discount. Hopefully it will be helpful, and you can grab the link through the chat, and the discount will be valid for 2 days only. And we will have the recording of this webinar. We'll share it with you as well. And again, thank you so much, everyone, for joining. And I hope you will have a nice evening. And we will keep you in the loop for the next topic and all of the exciting things that Plan Your Baby has to announce soon. Thank you.
Thank you, everyone, for joining in.
Thank
And yes,
you. Have a good evening.
wish you all good luck and success.
Thank you. Bye-bye.
Thank
Bye-bye.
you.
Bye.